All right, welcome to the last section in our lecture on shock. This lecture we will be talking about circulatory shock, which is also called distributive shock. So you'll see both terms used interchangeably. And this is a problem with the tone. So involved in distributive shock or circulatory shock could be septic, neurogenic, and anaphylactic. It's important to note that each of those shocks are circulatory shocks. So we'll go into a little bit of a deep dive and talk about them all. To understand distributive shock, you need to review the pathophysiology or the physiology of blood vessels, which contain smooth muscles in their walls. So when a smooth muscle relaxes, it increases the diameter of the blood vessel, called vasodilation. On the other hand, when a smooth muscle contracts, this decreases the diameter, and that's called vasoconstriction. The contraction and relaxation of smooth muscles is primarily controlled by the sympathetic nervous system, which normally maintains a sort of partial constriction, which gives us enough force to keep the blood moving through. And then sympathetic nervous system stimulation increases or decreases to keep up with the body's needs. So increased sympathetic stimulation of the blood vessels causes vasoconstriction, which increases our MAP. And vasoconstriction, when we have a constant blood volume, raises blood pressure and allows the blood to flow faster through the vessels. In contrast, dilation is typically caused by decreased sympathetic stimulation, in addition to inflammatory cytokines, and histamine can decrease mean arterial pressure. So vasodilation, when blood volume is constant, lowers the blood pressure and slows down the blood flow. So when we have a dilated vessels, that is considered relative hypovolemia. If we don't have a change in the amount of fluid, then we just have a change in the container. So that's relative, and that's tone. So remember, blood pressure is the force of blood against the arterial walls. So in all types of circulatory shock, the massive dilation promotes that peripheral pooling, and we end up with systemic vascular resistance decreased and vascular tone decreased. And with these distributive shocks, we will see often dramatically low blood pressures. So the first one that we're going to talk about is septic shock. Okay, so the main cause of septic shock is infections, particularly those that are caused by gram-positive bacteria. These are things like Strep aureus, Strep pneumoniae, Enterococcus, and then some gram-negatives like E. coli. And other source of infection would include viruses, fungi, parasites. Those can also cause septic shock. So therefore, the biggest risk are infection and then a compromised state. This includes people who are at extremes of age, so thinking about children or the elderly, anybody who has a chronic medical condition like diabetes, chronic diseases, anybody with underlying HIV infections, those who are on chronic steroid use, those with cancer being treated with chemotherapy. Other risk factors for sepsis include prolonged hospitalization, presence of indwelling catheters and other invasive devices, as well as surgery and having large open wounds. So the number of deaths annually is one of the most common cause of death for non-coronary ICUs in the U.S. So severe sepsis, the mortality rate is 50 to 60%. So this is a huge deal for us. So pathologically, the process starts when a pathogen, say bacteria, enters the body, goes into the bloodstream, and embedded into the outer wall of the bacteria, there are endotoxins, and these endotoxins are released when the bacteria is destroyed by the immune system, which activates immune cells, and then these immune cells release pro-inflammatory cytokines like the interleukins and tumor necrosis factor. So this ends up being an exaggerated response to the invading pathogen. So excessive and widespread inflammation. which is called systemic inflammatory response syndrome, or SIRS. This response causes increased production and release of stress hormones like our catecholamines and our glucocorticoids, as well as responses in our hypothalamus, on our vessel walls, in our capillary endothelial cells. Our stress hormones cause tachycardia and tachypnea and increased white blood cell production. And then some of those act as pyrogens, and then they raise the core body temperature, which causes fever. The vessel walls then start producing nitric oxide, which we already discussed is a vasodilator. And then the capillary endothelial cells stop giving their response to the vasoconstriction, and the endothelial barrier breaks down, which causes increased capillary permeability in other vessels, which causes the fluid to then move from the intravascular space into the interstitium, which results in systemic hypotension. In addition, these endothelial cells attract more platelets, which stick to those cells, making tiny clots, which are called microvascular thrombi. And all these changes in SIRS, they decrease perfusion, and that causes hypoxia. So that's how we get there. Included in this slide is the criteria for sepsis, severe sepsis, and septic shock, and some of the things you might see. So golden hours for septic shock, there's like a 6-hour thing, but honestly, guys, it's down to an hour. So we really have a golden hour at this time. And of course, we'd see the bacteremia. We had positive cultures, the bandemia, so left shift. And some of our labs may be abnormal. You can see them there based on the pathophysiology. In addition, insulin resistance. So people who have sepsis, even those who aren't diabetic, they tend to be hyperglycemic despite having no diagnosis of diabetes. So sepsis means that we have the SIRS criteria plus a microbial source. Severe sepsis is that we now have SIRS, the source, and hypotension. And then septic shock is defined as the sepsis, hypotension, SIRS with the source, and we've given them fluid. Total fluid volume replacement for them would be 30 mLs per kilogram, and they are unresponsive to that. So they remain hypotensive despite giving them fluids. So you can see here there are many different sources of infection and septic shock. You could just pause here and review. There's no need for us to talk about that further. I do want to back up to this slide previously, just so we can talk slightly more about it in the diagnosis. So some other things that I think that you should know would be that the CDC could show leukocytosis and neutrophilia with a left shift, which we've already talked about. It may show thrombocytopenia. If we did a CMP, it would show the hyperglycemia, and it could show some changes in organ function, including creatinine, bilirubin, increased lactate. The coagulation studies and electrolytes could be abnormal. And then we might have increased inflammatory markers. So something like a CRP, C-reactive protein, which is an inflammatory marker, tends to elevate and show us that something is going on in the body, and procalcitonin, and then even low levels of arterial oxygen. And because of the sources, we would want to have blood cultures, stool and urine cultures, any cultures from indwelling catheters, from infected lesions. Basically, we're looking to pin down the cause of the infection. And then we would also do things like echocardiograms, EKGs, imaging studies to determine the source. And when somebody has infection and sepsis, we are generally concerned about the heart. So the doctor may order an echocardiogram to make sure that the heart remains intact. All right, so the treatment of septic shock is here listed for you. So, and there's some notes on the bottom. So, of course, we need to optimize oxygenation because we have impaired tissue perfusion. And then fluids, 30 mLs per kilogram at a minimum. to correct the relative hypovolemia. And we want to look for clinical responsiveness to the fluid. So things like our vital signs, capillary refill, urine output. There's something called a fluid challenge, which basically we give fluids until there's a clinical sign of improvement plus some other lab values. So our CVP up in the 8 to 12 range. We could do something called the passive leg range, in which the person is laid supine and we raise the leg. And if they show increase in their pressures, then we should give more fluid because they're considered to be fluid responsive. So that's the first step in treatment is the fluid challenge. Second, if they're no longer fluid responsive or the fluids are not working, then we need to add some medication. So norepinephrine is the first line treatment. We may add vasopressin, which is antidiuretic hormone. So a reminder that if we add vasopressin, the expectation is that urine output would decrease as the body starts to hold more fluid in. We use it at a low dose, and remember, norepinephrine has to be carefully used in those with coronary artery disease. And then if that is not working to increase perfusion, then IV corticosteroids do have a place. So right here we have the 2021 Surviving Sepsis Campaign Guidelines, and the Hour One bundle is listed here for you. And basically, it is based on the lactate level, making sure we get cultures before administering antibiotics, and we give broad spectrum antibiotics at that time. And then there you see the 30 milligrams or 30 milliliters per kilogram crystalloids for hypotension or lactate greater than 4, and then vasopressors to keep the MAP greater than 65. The goal in the golden hour is to have those antibiotics administered. So at this point, if somebody presents with signs of sepsis or meeting criteria, the SIRS criteria, we would definitely want to get those cultures drawn right away and then get them started on that broad spectrum antibiotic. Remember, the culture helps us narrow down by culture track what the invading organism is. However, we would never want to delay giving the antibiotics if we are unable after trying to get those cultures. So, for example, I've had it where I was able to get one set of blood cultures, but the person was a terrible stick. They're hypotensive. They're very ill. We know that the antibiotics are absolutely necessary. So in those cases, with the consent of the doctor, I would then hang the antibiotic. But again, you have to let the doctor know. But in general, in NCLEX land, we're going to get those sets of cultures prior to any antibiotic. And then the difference between basically, let me move this over for you. Warm shock and cold shock. So the thing to be aware of is that patients with sepsis don't always present as cold and clammy, right? In fact, because of the increased body temperature, they typically, in the early stages of shock anyways, look pretty well perfused. In fact, they even have a hyperdynamic state. So you need to be very, very careful of that. So the person will have actually brisk capillary refill, and they'll have bounding pulses and no modeling of the skin. That is warm shock. That is a hyperdynamic state. The problem is that the body will not maintain that for too long, and eventually the person will go into cold shock. And at that point, you'll see the diminished perfusion, diminished pulses, modeling of the skin. If somebody's in a hyperdynamic state, they're probably in respiratory alkalosis, which then eventually goes to acidosis, respiratory acidosis, as they start to get tired, and then eventually metabolic acidosis. And the other thing to mention here is initially, as a person is diagnosed with shock, they may have a reduced ejection fraction, and it should, if we're doing well with the patient, should get better. And if not, this is very bad news. And remember that one of the sequelae of shock is ARDS, which we talked about under our respiratory section. So one of the biggest risk factor for ARDS is sepsis. So know the difference between cold shock and warm shock. And then also, just something in case it's ever asked on boards or otherwise, is that vasopressin is given with norepi. So norepi is a single first line, but we would never give vasopressin on its own. It's given with norepi. So that is septic shock. Remember, the other awful thing that can happen with sepsis is DIC. So our patients with septic shock, we need to be very careful and monitor them so very carefully. So for the care of a person with septic shock, remember, we're going to want to continue their fluid resuscitation, monitor their blood pressure, lung sounds for making sure that they are not going into either ARDS or circulatory overload. Monitor their labs. We should see a decrease in their lactic acid level, increase in their urinary output outside of the fact of vasopressin. And basically those signs of improved hemodynamic status, so increasing cap refill, increasing blood pressure, increasing MAP, increased CVP, and the urine output. So ongoing care will be monitoring their blood glucose and giving them insulin. Generally, we do glycemic control on septic patients. We'll need to provide stress ulcer prophylaxis with our PPIs. They will definitely need nutritional support through enteral nutrition if indicated, and prevent development of pressure injuries. And I think that will finish up septic shock. All right, so the next section that we're going to go into is neurogenic shock. So in neurogenic shock, basically in normal times of stress, we rely on the sympathetic nervous system to give us the ability to constrict our vessels. And neurogenic shock, basically there's a disruption of the autonomic pathways within the spinal cord. So instead, the parasympathetic nervous system starts to be the one in charge, right? So parasympathetic nervous system is in play, and the sympathetic nervous system is unable to exert its influence. And because of that, we end up with the hallmark signs of neurogenic shock. So we'll continue on to look at those. First, of course, risk factors. So basically spinal cord injury, especially anything above T6, a spinal anesthesia, which is why we keep the head of the bed elevated, certain medications, and people who have deficient glucose, so people with insulin shock. All right, so let's continue on here just a little bit. You can pause and look at the neurogenic shock with the different things, but the patho really is, because of the sympathetic nervous system unable to constrict the vessels, we end up with widespread dilation. All right, so the hallmark that we get if the sympathetic nervous system is unable to come into play is that we will end up with hypotension and bradycardia. So we need to be very careful in these patients because it's not a question of fluid, right? It's their inability. This is a tone issue. And then it can also end up as a cardiac issue as well if the bradycardia is causing the additional problems moving the blood forward. So for us, if they have any sort of an injury, remember we need to be worried about C-spine and always have an index of suspicion about that. We do give norepinephrine. This is first line for them. And also atropine for profound bradycardia. So as we're bridging to the OR, we did talk about that under section 5 for atropine and neurogenic shock. And the other things that we need to consider for neurogenic shock is the fact that although the patient will have venous dilation and pooling, remember they are unable to constrict their vessels. So they will experience something called poikothermia, which is the inability to regulate the blood pressure. So our patients with neurogenic shock, it is even more important to keep them absolutely warm. And so we would want to make sure they're in a warm environment, off of any cold surface, because they will assume the room temperature. They are unable to fix their temperature that way. Okay, and so the last one that we're going to talk about, I think it's the last one, yes, is anaphylaxis. So anaphylactic shock. So there's a picture of a Portuguese man of war here and of a little dog, because believe it or not, a Nobel Peace Prize was won for scientific discovery because the man of war was instrumental in the discovery of anaphylaxis. And they actually did some testing on dogs where this is where they found out the relationship between sensitization. And then the search was then on for a cure for anaphylaxis. And turns out there's really not a cure for anaphylaxis, right? This is why we have to really consider prevention as the best treatment for anaphylaxis. So let's just try and avoid it altogether. Okay, so the patho behind anaphylaxis is it is a type 1 hypersensitivity reaction, which is the IgE mediation of antibodies that binds and sensitizes the mast cells and the basophils. And then once the trigger reaches the body, it binds to the antibodies, stimulates those mast cells and the basophils to degranulate, and then at that point they release vasoactive mediators like histamine and bradykinin that cause massive systemic vasodilation. And remember, histamine also increases vascular permeability, which allows the fluid to shift out of the intravascular compartment, causing edema. So, and then mast cells also release tryptase, which breaks down the proteins and causes local tissue damage. So it is absolutely positively a potential that a person could lose up to 35% of their volume out of the intravascular space in the first 10 minutes. So the signs and symptoms, clinical manifestations, can be cardiovascular, like hypotension, tachycardia, chest pain, respiratory, which are typically associated with things like laryngeal edema, hoarseness, shortness of breath, stridor. There's often angioedema of the lips and tongue, meaning that they swell up. And then there could also be skin manifestations, which include flushing and itching, wheals. If the cause was due to like an insect bite or something like that, then there might be signs of at the site, at inflammation at the bite or wherever it happened. So the diagnosis starts with a history and physical. As far as labs, it might show high serum levels of histamine, tryptase, and IgE antibodies. We don't really have diagnostic criteria for scanning and radiology to rule in, but it can exclude possible complications of the shock. And then, of course, identification of the allergen. So if there are basically triggers, and there seems to be a lot of triggers out there, we can actually do pinprick tests to basically look for identification of allergens. So this is where small drops of allergens are pricked onto the skin to see if there's evidence of an allergy, like raised red itchy bumps or wheals. All right, so we already talked about the clinical manifestations and especially the organ systems that can be affected. And of those, probably the most important is, of course, the respiratory system. So in terms of treatment of anaphylaxis, we want to ensure airway patency, which in severe cases may require intubation, and administer epinephrine either IM or IV. High flow oxygen, including albuterol, IV Benadryl, methylprednisolone. These can be administered, and early resuscitation of fluids. So continue on here. The role of epinephrine. Remember, epinephrine is a vasoconstrictor and also works to cause bronchodilation. When in doubt, give them the epi, right? If you think that they look like they're in anaphylactic shock, if you have reason to believe that they may have anaphylaxis, it is better to treat and worry about it later. So again, IV or IM is better. IM is definitely better than sub-Q. And again, the best treatment really is prevention. So what do we do, right? So 100% oxygen, give them the epinephrine, steroids. Here's a list of medications. Remember the H2 blockers, those are adjunct treatment. So ranitidine and famotidine, which we are used to seeing under the PPIs and H2 for stress ulcer prevention, they can also help here by blocking histamine. And just a little aside here is that people on beta blockers may not respond to epinephrine, and if that's the case, then glucagon would be the treatment. So remember, the best care for anaphylaxis is prevention. Teach your patient to have medical alert bracelets, avoid their triggers, and definitely keep their epi at hand at all times. The sooner they get the epi, the better off they'll be. All right, guys, so this is the end of our presentation in total on shock. Thank you very much.